get rid of Dr. Diamond's presentation first.
Quickly, while Dr. Scheel is getting started, any physicians that are not presenting, our other meeting is starting in conference room 4. Thank you.
Well, good afternoon. It's nice to see some familiar faces and some new ones. My challenge today is to present ECD in the kidney. And if you look at any of the 6 major worldwide nephrology textbooks, ECD will not be in any of them. And so what I will present to you is not what's in the textbook, what's not in the literature, but what's my personal experience and that of my friend Dr. Vaglio sitting several rows back, who is also a nephrologist and treats ECD patients. Goal today is to review the kidney, some management complications, and how some of the medications that you are treated, how they may adversely affect the kidney. Well, from a very basic perspective, these are your kidneys, and your aorta will be here in the middle, and each kidney has an artery, each one has a vein, and each one has a ureter going down to your bladder. Blood flows in, it's filtered, comes back to the vein, and then urine goes down. ECD can affect one of 3 major areas. One, it can surround the kidney, or you can have disease of the artery, the vein, or the most common that we see is compression of the ureter so that urine can't get out and causes obstruction. This is a CAT scan, and you've become radiologists since your time here, but a CAT scan, what you're looking at is the patient's feet are coming out towards you, and these are sections through the midsection. Here's the aorta, here's each kidney, and you can see the artery here and the veins here, and you can see this gray area that surrounds the arteries in ECD can compress the arteries and can compress the veins, and so you don't have blood flow to your kidneys, or you can't have blood flow out of your kidneys. If this compresses the artery and becomes symptomatic, you can develop high blood pressure that's new, and this blood pressure can be severe. And if it's bilateral, meaning affecting both sides, it can also lead to kidney failure. If you have significant compression of the vein, this leads to large amounts of protein in your urine. And once again, if it's significant, can lead to kidney failure. The compression of the artery and vein leading to problems is very, very, very rare. I think I've only found 1 case report ever reported of this happening in ECD. It's very common in other areas. So patients who have atherosclerotic plaque inside their arteries, having blockage of blood flow into the kidney is very, very common. And there are other non-ECD conditions that can affect blood flow out of the kidneys. But for ECD, this will be very unusual. The good news is if it does occur, it can be treated. And in the 1 case that was reported in the literature, just like they can put a stent into your heart and open it back up, that's exactly what happens for the kidney. The radiologist, either through your arm or coming up from your leg, can put a balloon in your artery and then blow up a stent so that it holds the walls open. And so as the ECD is trying to compress the artery down, the stent's pushing back, allowing blood flow to your kidney. The second and most common reason that ECD affects the kidney is obstruction, meaning that your kidney's working great, it's producing urine, and it's trying to get out the ureter, and by compression of the ureter, there's nowhere for the urine to go. If you can imagine turning a hose on full strength, clamping it, that pressure builds up inside the hose and has to expand because it's under pressure. Lighting's not terrific here, but here is a normal kidney. You can see a ureter starting to dilate here, but this whole thing right here is a kidney that's obstructed with massive dilation of the collecting system. So the kidney is working great, but nowhere for the urine to go. And as I said, this is very, very, very common in ECD. We treat it with a different type of stent. And so here is a cartoon of the kidneys. And you can see this tube has been placed inside of the ureter. And up here in the kidney, this part of the tube has side holes in it. And so that as urine is being produced, urine can go inside the tube, come down into your bladder, bypassing any obstruction. I think what is not as well known, even in the medical community, is that if you look at all the urine up in the kidney, there's an awful large amount that not only goes through, but around the stent. And in patients with ECD that have extrinsic compression, the stent may not be good enough. And I do get a number of patients who come to me who said, I have stents in, but I still have blockage of my kidneys and my creatinine hadn't gotten better. And the urologist said, well, your stents are in, that's all I can do. Well, if your kidneys if the ureter is being compressed from the outside, then the stent's not the way to go. And in patients who have cancer, who have compression of the ureter, this type of stent only works in about 40% of people. And so it's not surprising that an ECD that also has extrinsic compression, that a double J stent may not work in that population either. The way to answer that question is through a nuclear medicine study. And I don't want to make you a nuclear medicine radiologist, but very simply, they inject a radioisotope into your vein. They watch that radioisotope go to your kidney. And once it reaches your kidney, in the collecting system, they time how long it takes to get from the collecting system to your bladder. Obviously, if it's blocked, it takes longer. If it's wide open, it takes shorter. And there are definitive time normal values. And so a normal person will travel from your collecting system to your bladder in under 10 minutes. If it's greater than 20 minutes, even if you have a stent in, it's not working. And so it's very simple to answer the question, is this stent working, yes or no? If the answer is no, then we're left with something called a nephrostomy tube. And not the favorite of people because they're left with a catheter out of their back and a bag hanging down with urine. But if it means the difference between having kidneys that work and kidneys that don't, most people will choose this option. And so what a nephrostomy tube is, instead of having this curled catheter here in your kidney with a stent going down to your bladder, it comes directly through the skin into the collecting system, and then urine comes out of your back into a bag and alleviates the problem of that compression of your ureter so that you can't have urine flow outside of the kidney. When I first started doing this, I was somewhat surprised, as stent management had always been something that my colleagues, the urologists, did. And I assumed that they knew everything that needed to be known about how to manage stents, and therefore I did not need to know that. I was wrong. What my urology colleagues explained to me is they use stents for one of two reasons. One is they took a stone out, and they need to put a stent in for a couple days until the swelling goes down. Or they have a patient with cancer who can't be operated on, and they put a stent in until they die. Putting stents in to have people have functioning kidney for years until medication works was not in their lexicon. And so when I asked them, well, how frequent do you change these stents? They said, I don't know. And some put stents in and assume that must have did something, they take them right out, even though they haven't received any chemotherapy to reduce the ECD. And so not that they're bad people or trying to do the wrong thing, this just isn't what they do. And like a lot of patients, a lot of physicians who treat ECD patients, things are a bit different in this scenario. And so this is what we have come up with, both for this disease and other diseases, is that stents can be made either of metal or plastic. If they're made of plastic, they should be changed every 3 months. And the reason they should be changed every 3 months is they form stone on them. And if you leave a stent in too long, they calcify, and when you go to pull them out, they don't come out. And that's not a good thing. And that can result in tear of the ureter and need for emergent surgery and all kinds of stuff. And so we have our patients have their stents changed every 3 months, and that's worked quite well for us. The same thing for nephrostomy tubes. If you do have metal stents, and metal stents are designed to stay in for a year, they don't have the issue of calcification, and for the type of diseases that we're talking about here, they've worked well, and we haven't had a problem changing them on an annual basis. Stents are not a panacea. They have their problems as well. And the most common complication is pain. And there's two types of pain. One pain is, and since the stents are changed every 3 months, the patient will say, "Doc, I swear to God, the first stent was great, this one's bloody awful. And it's the same exact stent, it's the same exact length and the same exact position, but one hurts and one doesn't." And for those of you who may have had stents, you know exactly what I'm talking about. The second type of pain, which is almost universal in everyone, is that as your ureter comes into your bladder, there's a valve. And so when your bladder contracts to expel urine outwards, the valve doesn't allow it to propel up into the kidney. When you have a stent in place, that valve cannot close, and so every time you urinate, urine goes out and it also goes up. And so people have flank pain on the side where their stent is when they urinate. That's very common. It's not dangerous, but it is one of the more common symptoms that people have with stent. The piece of plastic that's bouncing around in your bladder also can cause irritation. And once again, depending on the length of the stent, where it is, people who drive for a living, so I had a bus driver, and this was the worst thing in the world because they're constantly bouncing around in a chair, having this piece of plastic irritate their bladder. That can be an issue. Urinary tract infections is something we really, really try to avoid because once the plastic gets infected, it's nearly impossible to uninfect. And that becomes a nightmare as far as management of patients who develop urinary tract infections with indwelling stents. And I mentioned calcification before. This latter complication can be avoided by changing the plastic stents on a frequent basis. So we talked about the two areas that are most common would be compression of the blood vessels and the most common obstruction. The third area, and this is a picture that Dr. Hirosh was kind enough to send to me, is where ECD totally surrounds the kidney and compresses it so that the pressure compressing on the kidney is so high the blood flow can't get in. And outside of medications, there's very little that can be done about that. Here's the kidney here, and all this material outside is histiocytes, and on CAT scan, this is the so-called hairy kidney that people refer to when they see patients with ECD. Now comes a little bit more controversial area, and one that I think we need to do a lot better as physicians trying to understand is, what about the medications we give? Which ones hurt the kidneys? And is this something that we need to pay attention to? Dr. Diamond, in his ECD patients, as you noticed, he's very particular in looking to every particular brain lesion there is. As a kidney doctor, I'm very particular to pay attention to every change in kidney function, and perhaps, depending on what specialist you have treating you, is going to be very particular about their particular organ of interest. Well, certainly mine's the kidney. Of the typical drugs that we use, interferon, anakinra, you can't see here in red, is vemurafenib, rapamycin, cladribine, and the MEK inhibitors. Only two are really problematic. In fact, some of these drugs up here actually may help your kidneys if they're inflamed. And so the two drugs that I'll talk about, one is vemurafenib, and the second is cladribine. When we think about very basic terms about how your kidney could be injured by medications, we break them down into categories. So one is your kidney, for lack of a better term, could be allergic to the drug. And just like if you have taken penicillin and are allergic to it, you get a rash all over your body. Believe it or not, you can have a rash inside your kidney as well. And that swelling and reaction inside your kidney can lead to kidney failure. Some drugs can actually create what we call glomerular nephritis, which means an inflammation of a certain part of the kidney, and we'll get into that in just a minute. And then finally, the drug can be toxic to the tubules, and once again, I'll show you better pictures of what I'm talking about in just a minute. As far as vemurafenib is concerned, if you look at what the FDA has on file, it's not supposed to cause any problem with the kidneys. Yet, not the case in my experience. In looking through all the published reports, and these are not in ECD patients, these are in patients who received the drug for melanoma. There are 12 case reports of people who developed renal failure while on vemurafenib. They stopped the vemurafenib and the kidney failure got better. It certainly suggests that there was a relationship between the two. But in none of these patients did they figure out the mechanism. In none of those patients did they undergo kidney biopsy, nor were any detailed studies done trying to understand how the drug was affecting the kidneys. So no mechanism was known. I have 9 patients who are currently on the drug. and 4 developed a rise in creatinine on the drug. And so I was interested in that, and it taught me several things. One is things that happen to everybody else can also happen to people with ECD. And so last patient we biopsied, their renal insufficiency was from diabetes. It had absolutely nothing to do with the drug or ECD. The second patient I biopsied was purely scarring from the prior presenting of obstruction. And so the jury remains out. Does vemurafenib cause kidney problems, or are we just seeing common things that happens to everybody else? It's something that we don't have the answer to. And when I came to this meeting and started discussing with other people, do you see a rise in creatinine on vemurafenib? And everyone said, no, don't see it, never seen it. And as the meeting has gone on, I'm starting to get feedback. Yeah, I saw a couple of that. I just reduced the dose and it got better. And so I think we still have some work to do in that regard. As far as how drugs can affect the kidney, this is a cartoon. Within your kidney, you have millions of these units called nephrons. And this is the glomerulus. This is where blood flow comes in. And you have a filter here, and this is where the venous blood goes out. And as urine travels down this series of tubules, it exchanges with the blood system here in red. And each of these tubules are lined by cells that do different things along the way. I mentioned before that drugs can affect this area, or they can be directly toxic to these cells called tubular cells. This is an example of someone who's allergic to a drug. This is not vemurafenib and not ECD. Over here is a picture of a normal kidney. Each one of these is the glomerulus that I mentioned before. And the key thing to notice that these white areas, that is cross-section of the open tubules. So this is where urine is flowing through. On the right, you can see there's this tremendous number of these purple cells. These are inflammatory cells. And if I were to biopsy your skin when you had a rash to penicillin, you would also have a lot of inflammatory cells. And so this is the equivalent of a rash inside the kidney. What you notice are these tubules are not open because all of the inflammation and swelling is causing them to shut down. And that's why in what we call allergic interstitial nephritis, patients develop renal failure when they're allergic to a particular drug. The clinical presentation may present with a rash, as I mentioned, and kidney failure. The therapy is to stop the drug. Some would consider the use of prednisone to try to rapidly improve that inflammation. It's still a controversial topic within nephrology whether steroids affect the course of people who have allergic interstitial nephritis or not. Glomerular disease, I think if you can understand how this works, you can understand how a glomerulus works. You know when you go to drink your coffee in the morning, you put a filter in, you put the grounds in, and if you go to drink your coffee and it's full of grounds, what's the problem? You have a hole in the filter. Same things happen with the glomerulus. As I mentioned before, the glomerulus is a filter, and it's supposed to filter out blood and protein. And so if we go to look at your urine and it's full of protein, we know there's a hole in the glomerulus, and that the problem that we're looking for is at the glomerular level. And so when your creatinine may go up and your physician wants to look at the urine, one of the things we're looking at is, does it have protein in it, so we can try to pinpoint where the problem is. And so in patients who have glomerular lesions, they have protein in the urine, and the only way to diagnose this is through a kidney biopsy. Tubular damage, I mentioned before. These are the tubular epithelial cells that line these tubules. If you have tubular damage, you may have very tiny bit of protein in the urine. And there are specific tests that are now available on a research basis where as the tubular cells die or become injured, they release certain proteins into the urine that we can pick up. In Europe, this is available. In different countries, in the United States, it's not, and it's still on a research basis here. But from my perspective, what I hope to do in the next year is actually to take patients before we put them on vemurafenib, do the urine test, put them on vemurafenib, and see whether we see any release of these proteins from these tubular cells. If the patient were to go to biopsy, what you can see are these tubular cells look very sick and small and shriveled up, and is a sign that they've been injured, although it doesn't say what from. It's important when evaluating renal disease that we have to look at the trend of serum creatinine before the drug started. If and just because I'm using the term creatinine, I haven't explained it. So as you and I are sitting here today, we are breaking down muscle and we're making muscle. We've been doing it since we were born. And as you break down muscle, you release a substance called creatinine into your blood. And the only way it gets out of your body is through your kidneys. And so as you sit there and make new muscle and break down muscle, if the level of creatinine goes up in your blood, and we assume that production is the same, that the only reason why it should go up is that if your kidney is not getting rid of it as fast as it always did. And so we use creatinine as a marker in the blood to say how well the kidneys are functioning. Creatinine in and of itself is non-toxic. It doesn't do anything bad to you. But because it's being broken down at a constant rate and it's gotten rid of by the kidneys, we can say if the level builds up, it's because the kidneys aren't working so well. And so one of the things we can look at is, was your creatinine starting to go up before we put you on the drug? If it was starting to go up before we put you on the drug and the trend continued at the same rate, it's very unlikely that's due to the drug. Although we can't eliminate that, you do have to go back and take a look. As I mentioned before, we have to look at how much protein you have in your urine. And at the end of the day, we try to be as non-invasive as we can, and we either stop or reduce the dose of the drug to see whether that's beneficial or not. In ECD, we don't like to stop the drug, and we do reduce it to see whether we can improve things, and if not, we're left with a kidney biopsy or stopping the drug altogether, which we don't like to do. So, most common reason for ECD to affect the kidney is secondary to obstruction of the urine out of the kidney. Any medication, whether it be Tylenol, aspirin, or a blood pressure pill, can cause kidney problems. Doesn't have to be common, but it can, especially if you're allergic to the chemical compound. I think the lesson learned is that just because you have ECD does not mean you cannot have a non-ECD kidney problem, and we have to be cognizant that you could have a regular problem like someone else. And the key is that you have to investigate and figure out the cause. And at the end of the day, the final arbiter is a kidney biopsy. And not that everyone likes to have another procedure done or a needle stuck in their back, but it does answer the question once and for all. Is this a drug reaction or do I have something else? And then we can move on. And so if the choice is, do I stop a very effective drug because I'm worried about potential kidney toxicity, or can I find out the answer and continue the drug and get everything else better? I think that's a patient choice that we have to sit down and talk about the pros and cons. I can tell you that a kidney biopsy is commonly done. It's something that at our center we probably do 6 or 8 a day, not for this particular reason, but for other reasons, and it's safe and well tolerated. So it's not the end of the world. It can be done, and it does eventually give us the answer that we need. So happy to answer any questions that you may have.
Question?
No.
Okay. Did your urologist have any major problems in inserting nephrostomies in these patients?
You know, I can tell you that doing kidney biopsy on them, it's like going through concrete. And so, you know, normally when you do a kidney biopsy, you push it in until you feel a pop and you know you're inside the kidney because there's a capsule around your kidney. And when people have ECD, they have a lot of fibrosis, and it's almost like going through concrete. And so, yes, it's an issue, but we haven't had a problem doing it. But you kind of have to do alert your urologist or radiologist that this isn't going to be the normal course of things. And certainly as we do biopsies, we have to be mindful of that as well. Yes?
My urologist, when I had a stent in, said every 6 months was good enough, but you're saying 3, right?
Yeah.
Because I think I'm going to tell him that, 3 months.
Well, you know, the downside is the calcification issue. And
Okay.
if they get calcified and you can't get them out, then that's a major, major problem.
Okay.
And so it requires you to have it done more frequently.
Okay.
But I always err on the side of safety as opposed to convenience.
Oh, yeah. Well, is this something unique to ECD, that calcification, or can that happen just with a stent for
It
any
happens
reason?
to anybody with a stent.
Okay.
And like I said, most urologists put them in for a day or two, or because the patient's going to die in 3 months, they don't even worry about change in the future. So the concept of repetitively changing them over years is really not something they're accustomed to doing.
I gotcha. Okay. Well, yeah, because the procedure I had to be put out, totally put out. Yeah.
Yeah.
Under anesthesia. Okay.
Yeah.
If they, my son has the metal stent. Originally, they used the plastic and
Yep.
changed it out like after 3 months or whatever, then 6 months, and then went to the metal. And is that fine? I mean, he hasn't had any problems at all.
Yeah, so the metal stents were invented for people with cancer because of that extrinsic compression, and they've been around for about 2 years now. And so if you say, what's the large-term experience with them, there's not going to be that. We went to changing them once a year, and that's worked out well for us, and so we haven't had any problems with that.
Okay, thank you.
Is that for renal stents also, or?
So the renal stents, the one that's in the artery itself, they're permanent. They stay there forever. Yes, sir.
I had ECD take out both my kidneys. I had a kidney transplant. Do I have to worry about ECD affecting my new kidney as well?
I guess the answer is always yes, but the goal is hopefully your own medicines to prevent recurrence, and so it would be unusual for ECD to come back in that degree around your new kidney when you're on medication.
Okay.
Yes.
Dr. Scheel, by the way, thank you for diagnosing me. I was wondering, when I came to you with the diagnosis of retroperitoneal fibrosis, is Erdheim-Chester disease retroperitoneal fibrosis? Is it a version of it? Is it different? Or should we be using different vocabulary?
Sure.
And then the second part of the question would be, you mentioned at the very beginning that this isn't in any of the textbooks. How do we get ourselves put in the textbook so the thousands of people that are dying with Erdheim-Chester disease every year can be diagnosed before they die?
So 2 questions. One is, so Dr. Vaglio left, who's the other nephrologist from Italy in the group. Both of us, our primary interest is an area called retroperitoneal fibrosis, which is an autoimmune disease of your aorta that does lead to obstruction of your ureters as well. And so much more common disease. Have a couple hundred patients that I follow with that entity, as does Dr. Vaglio. And people with ECD are misdiagnosed with that and come into our clinics with the diagnosis of retroperitoneal fibrosis, and we say, well, I got some bad news for you because you've already been bounced around by 50,000 other doctors and have a diagnosis. Now we have a new one for you. And so that's how nephrologists got into the business of seeing patients with ECD, because they were referred for something else. Very different diseases, as I said. Retroperitoneal fibrosis is an autoimmune disease of the aorta, and it's treated very differently. And it's semantics, but retroperitoneal fibrosis is a disease itself. It doesn't mean you can't have fibrosis in the retroperitoneum. So it's once again seems like semantics, and many things can cause fibrosis in the retroperitoneum. Surgery can do it, ECD can do it, but they're 2 very different diseases. And the important thing is distinguishing them because they both have diametrically opposite treatments. And so one is not the other, and they need to be differentiated. As far as how to get ECD into the textbooks, I think it's going to be an uphill challenge because outside of Augusto and myself, we're probably the only 2 nephrologists in the country that see this disease and treat it on a frequent basis. And although we like to think we're almighty and powerful, it's just not the case.
Thank you.
Okay.
Dr. Scheel,
Okay.
it's very